So good morning to all of you. My name is Joaquin Duato. I'm the chairman of the pharmaceutical group at Johnson & Johnson, and I'm going to be moderating this panel on access, quality, and value in the U.S. healthcare system. A very interesting topic that I'm sure is going to raise debate and lots of interest and questions. We have a spectacular panel today, I believe, and I'm going to quickly introduce them, and I will let you afterwards say what you actually do. I'm just going to say your titles. But we have what I think is a spectacular panel. To my left, the first one, Jonathan Blum, who is the Principal Deputy Administration of CMS. And Jonathan will tell us later what you do in your introduction. Then after Jonathan, we have Chet Burrell, who is President and Chief Executive Officer of CareFirst, BlueCross, BlueShield. Thank you, Chet, for coming. Then after Chet, we have Carl Schmid, who is Deputy Executive Director of the AIDS Institute. Again, thank you also, Carl, for coming today. And finally, Mark Velleca. Mark is Executive Vice President and Chief Policy and Advocacy Officer of the Leukemia and Lymphoma Society. So a very interesting panel with CMS, a private payer, and different patient representatives that are going to give us a view of how we can improve and modernize the U.S. healthcare delivery system. As you can see from my accent, I'm not from over here, so you may experience some difficulties in understanding me during the session. You wouldn't be the first one. Lately, I went to my son's school, beginning of this year, to read a book on the Berenstain Bears, which is a very simple one. And when I was like 5 minutes into reading the book, one of the kids stood up and said, "Mr. Duato, would you mind to please speak in English?" So if you experience the same thing, please don't hesitate to raise your hand and tell me. Good, so I was reading the notes preparing for this session, and I came across a quote from Secretary Sebelius saying that the U.S. lives in the 21st century with a healthcare delivery system of the 20th century. And one of the discussion points for today is how we can harness the power of technology, the power of innovation to modernize the U.S. delivery system. There's a lot of things going on in the U.S. delivery system. Because of my job, I have the opportunity to take a look at many places of the world, and I can say that right now the U.S. is perhaps the place where there's more experimentation, more piloting in different type of models, from payment models to electronic medical records in many different areas, and I would say is where the action is happening now. So let's start by asking each panelist the same question and asking you to introduce yourself. So the question, and I start with Jonathan, would be, please tell us what you do in CMS, and also tell us what you think is the biggest opportunity or challenge that the U.S. has in order to improve our healthcare delivery system.
Great. Well, thank you for the opportunity, and thank you for the panel. This is a very timely discussion and a great fellow speakers here on the panel. My job at CMS is the principal deputy, which means that I do a lot of things in different parts of the agency, but the primary work that I do is to really help the agency think about its care delivery strategies, its cost reduction strategies, coordinating payment policy, coordinating innovation, coordinating the work for the Center for Program Integrity to build unified strategies to reduce cost, to improve quality, to improve care coordination. I think right now we are at a tremendous time, particularly with the Medicare program, and the data that we are seeing coming in from different channels, different data systems, has led us to conclude with greater confidence that the three-part aim that the agency has pursued since the Affordable Care Act, it's no longer theory, but it's actually working. And what I mean to say is that it used to be the notion that there was a trade-off between quality and cost, between access and cost. And particularly in the Medicare program, what we are seeing is that we can do three things at the same time, that we can add benefits to the Medicare program, and as folks in the audience know well, the Affordable Care Act worked to expand benefits through the Part D drug program, through more preventive benefits, through the traditional fee-for-service program. We can substantially elevate the quality of care, and just about every care measure that we track on right now is going in the right direction. We are seeing dramatic declines in hospital readmissions, and we can reduce the total cost of care, kind of per capita basis. And so all three of these things, benefits, quality, costs, are all going in the right direction. And those that track on the real minute details of CMS payment policy probably noticed a statistic that was put into our health plan rate notice that came out Monday night. And the statistic is that the actuaries, for the rate notice purposes, projected that cost trend for the Medicare program, fee-for-service and MA, is projected to grow at minus 3.4%. Now, when the notice came out back in February, that trend was projected to be negative 1.9%. Through new data, through new assumptions, our actuaries now are projecting even dramatically lower cost growth for the Medicare program for the next several years. And this is a historic time, I think, for the Medicare program, but for the entire healthcare delivery system. We are seeing quality go up across the board in all of our payment systems. We are seeing benefits being added to the program. We are seeing better patient experience. And while this is happening, costs aren't going up, they're dramatically going down. And so I think what the real innovation is that we have confidence and we have momentum, and we'll continue to build payment policies, build incentives, build care delivery systems that continue this strategy of better benefits for patients, better quality of care, better care coordination, and total cost of care coming down dramatically. And that's been our strategy, and I think right now we are seeing the data to prove that it's true.
Thank you, John. So let's move into Chet. Chet, tell us what you do and what do you think is the biggest opportunity or challenge?
I am the CEO of CareFirst. It's a BlueCross and BlueShield plan that covers Maryland, the District of Columbia, and Northern Virginia. We are the biggest carrier in the region. Other than Medicare, CHIP, and Medicaid, we cover the majority of the population in this area. So we cover something on the order of 38,000 small groups, hundreds of thousands of individuals, most of this under 65 in age, and then we cover Medicare supplemental products for the over 65 population. So this all amounts to about 3.4 million people outside of government programs. We have spent a considerable amount of effort, resources, and thinking on how you would design a different delivery system, how you would incent providers to get better outcomes, both on quality and on cost, and the third on accessibility. And we have launched to that end, we think, the largest primary care medical home program in the United States that is now in its 4th year of operation in this area. I'd like to echo some things that John said. What we have found out is that in this region, historically, year after year after year, overall medical costs were rising roughly in the 8 to 10% range every year. And at that rate, they were doubling every 7 to 10 years, to the point where employers and purchasers were saying this is flat out unaffordable. We implemented the program to give incentives to primary care physicians to manage the holistic need of a patient, particularly concentrating on chronic disease, medications, and overall care coordination across multiple sites of care, not just primary care. In the 3 years that the program has operated, we have seen trend drop to less than 2%. And at the rate that it's going to turn negative here, perhaps this year, we don't know. But the decline has been dramatic. We don't think it's solely because of the program, but we think the program contributed greatly. We're focused on the 10% of the people, in our case, that consume 65% of the total spend. And these are typically multi-chronic or catastrophically ill patients. and as well on people who are not that sick or who are well today, and you want to keep them there by increased awareness of their health status and their health risks. There are 5 things that we see coming together that are so important. The rise in demand associated with chronic disease, sedentary lifestyles, poor diet, and the mentality we think that we see in the population at large, which is, fix me. I want a pill. I want something that will fix me. I don't want to have to change necessarily what I do. How do you counteract that? We see a fragmented delivery system where it is very difficult to say who is accountable. Who is the quarterback? We chose the primary care physician, realizing that the bulk of the care is actually done through specialists. And so which specialist you go to matters greatly. We give information online to primaries to that end. Reimbursement, fee-for-service reimbursement, inflates volume. We put powerful checks against that with global expected cost of care targets so that there's an incentive to keep costs down. There are coverage limits, John mentioned this, that we think are critical in the way things are covered by insurance policies that get in people's way. And we have tried very hard to overcome those limits. We often find that for the sake of a $20 copayment, people don't take their medication, break down, and then you have the admission and readmission pattern. And then the final, I would say, is an insufficient set of incentives for wellness. What is it? Do you get the safe driver credit? What do you get when you live a healthier lifestyle or you become healthier? And how can we introduce more powerful incentives to do that? And we have some things that we have now put into the marketplace in that regard that I'd be happy to talk about if we have time. So it's the coming together of a number of things, not simply doing one thing better. And let me just echo what John said. We found that the only way to improve costs control is to improve quality. They are not antithetical to each other. Quality improvement is essential to cost control. And you cannot do the one without the other.
Thank you. That's an optimistic message from both of you that you can improve quality and lower costs. We'll talk more about that later. After that, Carl, tell us what you do in the AIDS Foundation and your point of view representing a patient organization.
Sure, thank you. I'm Carl Schmid. I'm Deputy Executive Director of the AIDS Institute here in Washington, D.C. We're actually headquartered and founded in Tampa, Florida, and we're national advocacy and public education organization focusing in HIV, but also more and more in hepatitis and other chronic illnesses as well. In terms of the greatest opportunity that we see, and we feel that's the Affordable Care Act. We really feel we're very supportive of it. You know, you guys have been doing a wonderful job of getting, developing medications. And now we have an opportunity to, get those medications and coverage to so many more people. I don't think I have to tell anyone in the room here, what you've done for HIV and how the treatments that have been developed have remarkable progress in saving millions and millions of people's lives around the world. The drugs are getting better and better, and instead of taking numerous drugs, they're now combined into one pill a day. It's just remarkable, and they're getting better and better, and they're more tolerable. But to get coverage for the ability, payers for those medications and getting the drugs to the people are important. And just personally, how I've been affected by the remarkable advances. I have chronic hepatitis B, and for much of my life, it was very difficult to just do things on a daily basis. And I was denied health coverage because of my pre-existing condition. So with the ACA, we're going to see changes. People have more access. I'm also a cancer survivor and have had lymphoma. And, it's the medications that you've developed have saved me, have saved countless people around the world. But now, we have a payment system, hopefully, that will get more drugs to more people and save more lives. So that's a great opportunity. Now, the greatest challenge is also the ACA. It was a very tough start. We just went through the website and the enrollment process. Hopefully, we'll see much more progress next year. But the Medicaid is a state option, and many states are not, around half of them are not taking the expansion, and we feel that's a real mistake. And particularly for the southern states, there's a lot of people who are not in care, particularly in HIV and other chronic conditions, who are very poor. We would like to see that more states take the Medicaid option. So we hope that will change. We're still in the early stages of implementation, and I think we went through the enrollment process. Well, now people are starting to go to their doctors, and so now we're going to really see if it's working, and I think that's a real challenge. Are the drugs on the formularies that the patient needs? And then how expensive are the drugs for the patients? We're finding that, the cost, it could be, really prohibitive for patients. Instead of maybe paying $40 a month, they're having co-insurance of 50%, which could be $1,000 a month. So are patients going to be able to afford it? And with HIV, you have to, once you start taking the medications, you have to continue to take the medications and adhere to them. And it's very dangerous to have any treatment interruption. So access to medications, but what about access to their physicians as well? I think we're going to have to wait and see how that is working as well. So, we're seeing some other challenges and we're in concerns in the marketplace. And the other challenges we're very concerned about is making sure that those practices are not brought forward to other parts of the market as well. So we have great opportunities, but challenges as well.
Thank you. Thank you, Carl. Mark?
Yes, Mark Velleca, the Chief Policy and Advocacy Officer for the Leukemia and Lymphoma Society here in DC. We're actually headquartered in New York, and we have chapters across the US and Canada. We're a 65-year-old patient advocacy organization, and our mission is to find cures for the blood cancers and make sure that patients can get access to innovative treatments. And since our founding 65 years ago, we've invested $1 billion into finding cures. And that research that we have funded has touched every therapy that's been approved by FDA in the heme malignancies in the last 40 years. So to the question of opportunities and challenges in healthcare delivery and reimbursement, I'm going to also focus, like Carl did, on the ACA and start first with the opportunity. I think there's a huge opportunity for improving public health in this country because of ACA's focus on wellness, health maintenance, and subsidizing prevention and screening. Very, very important initiatives that ultimately will have impact overall on the public health in this country. However, consider those diseases for which there aren't prevention or screening strategies, and that would be the blood cancers: leukemia, lymphoma, multiple myeloma. If there are no screening and prevention strategies, the focus has to be on innovative treatments. So for those patients, I think there are certainly challenges presented by the ACA. And maybe to illustrate those challenges, you can think back to Velleca's very powerful story in the earlier session. And if you think of a typical leukemia patient who presents to the healthcare system with an acute illness that needs treatment now, what are the challenges and barriers to care that they face? Well, first they have to find a treatment center. And I think we have heard in many of the exchange plans about narrow networks, about NCI, comprehensive cancer centers, being excluded from some of those networks. And that's obviously can be an issue when a patient needs to see a specialist. So that's the first challenge. The second challenge is obtaining a precise diagnosis. And this is where the science is moving so fast that I think the regulatory and reimbursement system has not caught up yet. We are moving from a one test, one drug companion diagnostic world to a companion therapeutics world. Increasingly, patients are going to get a very sophisticated set of molecular tests, and based on those data, they are going to get a sophisticated set of therapies that match that profile. So the entire reimbursement, both the approval system for diagnostics and the reimbursement system for diagnostics needs to catch up with that and go from companion diagnostics to companion therapeutics. And then the third is affordability of these therapies to our patients. Cancers now become, much like AIDS and Hep C and other diseases, a chronic disease. And therefore, there are ongoing costs associated with taking therapies potentially for the rest of a person's life. So there's clearly data that compliance with those therapies goes down as out-of-pocket costs go up. So and I know this is a topic for further discussion, we clearly need to come to grips with how we can increase affordability of these therapies for our patients.
Thank you, Mark. Thank you to all of you for the introduction. So now we're going to move into a round robin of questions. I'll tell the audience that this is a 90-minute session, so there's going to be ample time for Q&A. So if you have questions, think about them, and we'll have time to do it later. So clearly, there are several topics emerging, payment models and the impact in cost and quality, and how we can use the opportunity of ACA to improve the payment models to drive the triple aim that you were describing. Clearly, topics around access and affordability, and particularly in the context of ACA, the exchange plans, but also Part D. But before I go there, I wanted to ask John about something that has been in the cover of all the newspapers today, and his name was quoted there yesterday, so I wanted to ask him about something that may be in the minds of the audience, the Medicare report. Give me your view on the Medicare report and how you interpret the data. There's been lots of interpretations, so I would like to hear from you. And if you guys want to chime after John, that I would welcome down too.
So I think part of our strategy within the agency has been to become much more sophisticated users of data. And whenever we put in place a controversial payment change, like a dramatic reduction for durable medical supplies, a new bundled payment model for dialysis services, we now construct very sophisticated data sets to track patients moving through time, moving through providers, and we can see issues very quickly and act upon those issues, but also have confidence that patients aren't being harmed whenever we reduce payments or change payment models in a dramatic way. We also use that same capability to do much more sophisticated work around program integrity, to spot trends, to spot outliers much more quickly than the agency could in the past. And that has been very beneficial to bring recoveries at an all-time high and fraudulent recoveries and overpayments. But we only have the capacity to look at data given our current resources, our current staff. And we feel that the public has a right to know, with privacy protections in place, where Medicare dollars are being spent, how they're being spent, to help other payers, to help other care delivery systems learn and to kind of see patterns of care, best practices, and to help the agency and to help the public understand whether spending variation is warranted or whether it's unwarranted. And part of our strategy in the last 4 or 5 years has been to liberate our data, to make it more accessible, to make it more user-friendly, particularly on the traditional fee-for-service side of the Medicare program. We took a major step last year where we released hospital charge master data and said this data doesn't make sense to us. Help us understand why hospital charges vary so much across the country, vary so much within a geographic area. And no one really gave us a great answer but to say, well, it doesn't matter because nobody pays charges anyway. Well, many people do pay charges, and it's a huge policy issue. And we took another major step this week, putting out physician-level information with privacy protections in place that is now beginning to raise very important questions of how we are how we are spending Medicare dollars, where they are going. And some of the questions that have come up in the last couple of days obviously have been the tremendous money the Medicare program spends for physician-delivered pharmaceuticals, for ophthalmology services, for cancer treatment, and the public and the press are raising very important questions. And our goal is to foster that conversation. And some of that conversation is not very comfortable for CMS, but we think that the public policy value far outweighs physician privacy concerns to have that data. We want payers to use it. We want care providers to use it. We want those who are forming ACOs to understand which physicians drive better performance, better value for the Medicare population. We want the public to raise important questions for how we are spending very valuable resources. And can our quest for the three-part aim, there's many different elements that go behind that strategy, but data liberation is part and parcel to that strategy.
Thank you. Chet, any comments from your side?
Yes, I maybe put a couple of things in perspective. We're a payer, as I said, that's mostly focused on the under 65 population, although we have a substantial enrollment over 65, Medicare fee-for-service. A couple of interesting statistics that I think denote the challenge. It was just this year that we found that we are spending more on pharmaceuticals than we are on inpatient care. There's never been a time in history where that has even been close to true. So we spend today nearly 1/4 of all that we pay for in the form of one drug or another. Of that, nearly half of it is spent on specialty pharma, infusible or injectable or, quote, large molecule drugs, biologics, which hold great promise and also great cost. Hepatitis C, $84,000. Synergist, respiratory syncytial virus, $1,000 a shot for a child. I mean, the costs are enormous. The benefits are as well. And we're looking at the balance of that. We also track costs across the region, and I think this region is illustrative of the country as a whole, by episode of care. Hundreds of different medical episodes of care and procedural episodes of care. And total cost within the episode, all things in. And within the region, here, there is within every single episode group over 100% variation in cost, depending on where you go. And that variation is not correlated to quality. And so one of the things that we're looking at and helping primary care physicians with is, can they be helped to discern the differences in cost, not just the differences in quality? It goes to what information is available. And for treating providers, we have found ourselves in the place of putting the equivalent of 300 libraries of Congress online, instantly available 24/7 to treating providers. Not narrowing networks because of the consequences of that, but allowing better choice of specialists with a combined view in mind of quality and cost. And again, if there's an adverse situation with quality, we cause the primary care physicians to be accountable for that. So they have every reason to be careful. These things are now taking hold in this region, and we're also starting to apply them to the Medicare population and seeing change. And we think largely the reason that the experience has been to bend the curve has been because of things of this nature. Data is essential to insight, and insight is essential to action.
Thank you. No, it's certainly a way in which we can improve the healthcare system by using data in an intelligent way to drive quality. But let me go into Mark or Carl. Any comments on the topic of the Medicare report and the references that John did? Maybe Mark, in your case?
I'll just point out most people probably know but don't really think too much about unless you have a chronic disease, is that many of the treatments that you receive in the hospital or in a physician's office, the cost is you don't realize what that cost is. If you have to show up at the pharmacy counter and pay a copay, it's very apparent to you. So I think we do need to keep in mind the costs that pass through to a patient and those that are absorbed by the system, i.e. in this case, Part B.
Thank you. So let's go into affordability and cost, and let me start back with John. How is CMS monitoring and seeing the plans that are coming from the exchanges? What role does CMS play in that context? How are you monitoring what is occurring there, in particular as far as the benefit design and as far as the formulary options for patients?
So one of the things that we did on January 1, when the new coverage year started for those that had signed up for exchange plans before January, that we put in place the same techniques that we use on the Medicare side to monitor, to assess, to set up hourly phone calls with pharmacy organizations, physician organizations, patient groups, really to understand what is happening on the ground. We do this on the Medicare side every new benefit cycle because there's always changes, and it really gives us a really great picture, best we can, to assess what's happening to care delivery. And so we are using those same tools, those same techniques across the agency to monitor, to assess, to have real-time conversations. We hear from patient groups that we can act on very quickly and do our best to intervene with plans and any true access concerns that are discovered. And one observation that we have as an agency is we had the hypothesis that when individuals came into coverage, the experience would have been very similar to the experience during 2006 during the Part D transition, where millions of beneficiaries transitioned from Medicaid coverage over to Medicare coverage, and there was system failures, and many beneficiaries did not get drugs point of access. That didn't happen January 1st, 2014. So it's giving us confidence that the transaction systems, the benefit systems that are being operated by those participating in exchange plans are working well. We do hear from patient groups about plan formularies, and we make sure that the plans follow the rules. But we have systems in place. They were deployed December 31st, January 1st throughout. They will continue to be in effect. But the experience from the Part D transition has given the agency valuable tools, valuable lessons that we applied this year when new coverage began. But we feel confident that the kinds of major access issues that were experienced back in 2006 have not borne out so far, but Chet may have a different experience.
Well, I think in the private market, I'd just make a couple of observations. We have been very strong supporters of the ACA, and in this particular region, over 150,000 people have come in, at least to coverage with us since January 1. And half have come direct and half have come through exchanges. I just want to make so there's great hope, I think, that the ACA will actually increase access. And it was mentioned earlier, and I just want to underscore it. There's some things about the ACA that are going to be challenging. Let me just draw your attention to a few. You know, platinum, gold, silver, bronze plans. Let me describe a bronze plan, because most of the people who are buying silver and bronze. Here's a bronze plan. $4,000 to $6,000 deductible, $6,600 out-of-pocket max, drug integrated into the deductible so that it's not a question of going to the pharmacy when your doctor says you need a prescription and paying a $20 copay. Mrs. Jones, you owe us $187, the whole price of the drug. And so it is woven into the nature of the designs. Yes, the Affordable Care Act increased essential benefits, health benefits, that is true. It also increased the amount of cost share, and that is also true. So it'll be interesting to see what that does with regard to access. Secondly, there's a reset every year of deductibles. So if you have a $4,000 to $6,000 deductible, and you are with chronic disease, you're going to see that reset every year. And that, we're worried, becomes an obstacle to access. The third thing is that the heart of the Affordable Care Act says there shall be guaranteed issue, everybody can get a policy, which is a good thing, and there will be community rating. Everybody's in the same pool. So if I live a healthier lifestyle, if I do anything that increases the quality of my health, I get no reward. I can't get a reward. And because the rate is the same. And we're worried about the long-term implications of all of these things, even though we are tremendous supporters of the Affordable Care Act. How does one offer large scope coverage to drugs and to providers and hold it affordable? And so we have come down to incentives to physicians, and particularly to primaries who holistically should know the patient the best. We have focused on the core of multi-chronic diseases, metabolic syndrome, the common things, diabetes, hypertension, heart disease, mixed together in the single patient. We see patients in the under 65 market commonly with 20 or more prescriptions at the same time. It's not just a question of what's in the formulary and what the price is and of individual drug. It's, are you on too many drugs for basic things that are common in the population? So we've looked at offering incentives for wellness outside of benefit designs, and we're going to introduce those in the marketplace to individuals, rewards. And we are looking at something, and we'll implement it at the beginning of 15, which is, as far as I am aware, no one is yet doing, which is to say that if you have you're multi-chronic and you have a situation that is ongoing, and you're in a care plan with the consent of your primary and the direction of your primary care physician, we will waive your cost sharing on 3 conditions.
Let's hear the conditions.
They're common sense. The first is that you consent and that your physician believes you need it. Not us, your physician. The second is you comply. You actually do what's in the care plan. And the third is the waiver will extend so long as you need it. In other words, if you get better to the point where that's no longer necessary, then there's a graduation from the care plan. So the whole idea behind cost sharing has historically been sensitize people to the cost and make them aware of the cost and don't have frivolous use. But if your doctor says you need it and you have multiple chronic conditions and you're on prescriptions that you should be on and that has been looked at, and you agree to have your care coordinated, and you agree to be engaged, then we will waive it. And we have started to do this for tens of thousands of people. A lot of the actuaries tell us, be careful, it'll actually lead to increased cost. And I don't know. But we felt that we had to do that because, as I said earlier, what we see is people not for $1,000 or $4,000 or $6,000, but for $20. Not complying with what they should comply with. They break down, they have ER visits, and for us, every admission is $20,000. And we would like them to be more enlightened about their need, more careful about their coordination of their care, and more engaged in it. And if they do that, we'll help them.
Thank you, Chet. Great to hear about the incentives and different payment models that you are using to try to drive quality and reduce costs. But following on the access and affordability issue that you started with the conditions of the plans coming from the exchanges, it would be good to hear from the patient community. And I know that Carl was quoted also in an article yesterday about the profile of the early enrollees in the exchanges and the disproportionate share of HIV patients that exist there. So how is your patient community seeing access to medicines and services within the exchange plans?
Well, thank you. You know, we're seeing some disturbing trends, and some plans, not all, seem to be putting every hepatitis drug or HIV drug on the highest tier. And and they're also putting high coinsurance, 50% coinsurance. And it's every drug in that class. So, I mentioned earlier there's combination therapy right now for HIV, and that would be ranked, in this plan just along a single tablet, a single drug, one component, or a drug that's not even used much anymore. So, we feel this is discrimination, and there is, very strong language in the Affordable Care Act that says you cannot, discriminate based on a condition. But to put every single HIV drug or hepatitis drug, no matter, the quality of the drug, how old it is, if it's used or not, on the highest tier with 50% coinsurance, we feel is discrimination. And, so we'd like to see action, by CMS on this issue to enforce the law. And we feel that, it's not all plans, but we're concerned that who's going to stop if there's no enforcement right now? Who's going to stop the good plans this year from becoming bad plans next year? And that all drugs in all plans would be given this. The other thing I mentioned is the high co-insurance. These plans are supposed to be based on the typical employer market, and you don't see 50% co-insurance in the private market. And so again, this is a disturbing trend, and we would like to see a limit, maybe $150 a copay. And the other thing is that the patients we need some transparency, because the patients see 50% coinsurance. They have no idea what that means. First of all, they're used to, one, are they knowledgeable about insurance at all? And they have to learn about premiums. Then they have to, I think copays are a little more common, but now coinsurance is something, that people are not accustomed to. And they don't know what the 50% is of. So is it $100, or is it $1,000, or is it $2,000? And for a lot of HIV drugs, they're very expensive. And so for a patient, not only are they paying their premiums, but now they're going to be, they're shocked when they get their first bill of $1,000 or so for their drug. So again, we would like to see some transparency. We're also seeing more use of prior authorization as well. And when it's for every HIV drug, that sounds like discrimination again. The doctor prescribes a drug for what they feel best suits the patient's needs. And they do resistance testing, and and then to go through a prior authorization is just unnecessary. I mean, I could see there's some, drugs that need it, but limited. And so we'd like to see that limited as well.
Thank you, and I'll come back on these topics to you two later, right? Particularly to you, John, but before we go there, I would like to ask Mark also, representing your constituency, not only on the exchanges, but also in Part D and in Part B, how is the issue of affordability impacting?
Yeah, I can certainly echo all of Carl's points about what we're seeing in the exchanges. Maybe highlight two additional points. One is and Chet did mention this, the tremendous geographic variability. You could be on a silver plan in one state and have a drug that did get put on a high tier, but it's a $50 copay, which a patient can budget. They can expect that expense on a monthly basis. Move over one state and it's a 50% coinsurance. So the concern is the ripple effects that this will have and punish those that were offering these lower copays that patients can afford, and what's going to happen in the commercial marketplace going forward when people start looking at employer plans in the coming years. Will these very high coinsurances going to become part of the norm? And that would be very disturbing for our patient population. As far as CMS and Part D, we were very pleased to see the protected class issue, which was some guidance had been issued a few months ago. Those protected classes are critical for our patient population. Immunosuppressants, anti-neoplastics. We had some initial concern about formulary coverage in the exchanges. Again, pleased to see that most of the drugs that our patients need are listed on those formularies. The issue is, again, getting to Carl's point about them being placed on a specialty tier.
Thank you. So now going to John, I mean, when you listen to the issues with cost setting and co-insurance, how does CMS think about that?
Well, I feel most comfortable talking about the Part D experience because we have obviously a longer period of time and better data and better experience to talk about some of the issues that were raised about the trade-offs between tight formulary management, cost sharing, and premiums. And so in the Part D side, every year we get pleas for CMS to change, to lift the so-called specialty tier and to lower cost sharing for drugs that are higher cost. And we have resisted those changes for two primary reasons. One is we are confident that when you lower that cost-sharing threshold, you translate those costs to higher Part D premiums. And a lot of the feedback that we heard this winter regarding the proposed Part D rules, that Part D premiums have stayed low, and that's a good thing, and CMS should continue that trend. And if we were to change that, those costs would get passed on through higher premiums. So it's always a trade-off and always a balance that you have to strike. The second concern that we have is that if we lower the patient cost and in effect raise the cost burden to taxpayers and to the government programs, I believe, and this may be a controversial statement, but I'll say it, that's going to transform pharmaceuticals pricing models and how they choose to set their prices. And so we believe, and we feel comfortable saying this, that part of the reason that drug prices get set how they get set is taking into account the insurance coverage and the cost-sharing burden, and that drives, the ultimate price that gets charged to payers and to consumers. And so we have to strike these balances. And CMS did propose, and we stepped back from taking a fresh look at the protected class issue, but we were trying to take a fresh look in a very careful way, very sensitive to patient concerns, how we strike these balances. But to us as a payer, the Part D program, best experience, simply to lower the cost-sharing burden, puts pressure on other areas that we have to be very mindful of.
Chet, what is the view from the private payer side?
It's a very tricky balance. We have spent a great deal of effort looking at ways to cut down pharmacy cost. The most obvious way, immediate way, is we have been able, through a competitive bid process, to lower ingredient costs 10%. And on our volume, that's a lot of money. That passes directly on to our premium payers. We're a nonprofit, so we don't hold it. It goes right to them in the form of lower payments than otherwise would have been the case. But I think what I was trying to raise before is a somewhat different view, which goes back to the concept that if you think of a pyramid, the very top of the pyramid are the sickest people, and the top 10% of them are 2/3 of all of the spend that we have. So the question becomes, who are they? And what do they need? And how do you get it to them best? And these are typically people who are seeing multiple specialists, multiple pharma, multiple imaging, multiple everything across many settings over time. And in the traditional healthcare system, this is uncoordinated. It's fragmented. You do what your neighbor says, you do what your mother says, you do what your brother says, and you pick it out. So what we have done is put a great deal of emphasis on identifying those people, working with their primary, but also with the team of specialists that they work with, coming up with a plan of care and asking them to comply, and then, and only then, mitigating cost sharing. But doing it then, because we are saying this is in fact what you need. We also sponsored legislation, by the way, in Maryland, or supported legislation in Maryland that would limit the co-payment on specialty drugs to $150 so that you didn't have co-insurance that nobody understands what the outer limit is, which converts into ill will and discontinuity in care directly. It's a very tricky balance. And so I understand and agree with what John is saying. As we have applied this in the commercial market, we're looking for efficacy, aggregate effect. Drugs are powerfully important, most important treatment method. They're 1/4 of our spend, but there's 3/4 of everything else. And what we want to make sure is you don't, for the lack of the drug treatment you should have, run up excessive costs on everything else. And it causes us to have to focus on the very top of that pyramid, which mostly is multiple chronic disease of the common variety, over and over and over again. And that's what really runs it up. And so we've looked at how to deal with that and then get people aware of the lifestyle conditions that actually cause them to have multiple chronic conditions. And that's what I meant earlier. There's insufficient room right now in the legal framework for the way benefits are established to establish incentives towards healthier lifestyle. And it's something we want to work on very much in terms of future iterations of the Affordable Care Act, and we're looking for ways outside of benefits to give incentives towards wellness. And so it's no one thing. It's the combination of all of this with an engaged, involved physician leader and quarterback who has a stake in the outcome,
Yeah,
not just the patient.
You raise a very good point as far as the frame of saying, okay, you have 25% of spending drugs, 75% of others. When do you look at the total healthcare spend, medicines are 9.3%, so 91% is something else. So the other elements, the coordination of the other elements is very important. And in all the projects that have been focusing on the super utilizers, as you were describing, what you see is a reduction on the other cost and even a slight increase on the medicine cost.
That's right.
You know, with the consequence of the reducing the overall cost.
I was very sensitive to one of the points that Carl raised, which was if you take the cocktail that a HIV patient is on, or even in any other disease, that gets carefully tuned because they understand the need of the patient, and then you put every one of those elements through some pre-auth process and put each element on a different tier on a formulary, you have just thwarted all your chances of getting a better outcome. And yet that is the traditional way of thinking, and that is, you're right, that is what is the traditional insurance company approach to it in the commercial market, and that's what we're trying so hard to counteract. And, but I can understand why the commercial insurers and other insurers do it, is competing in a marketplace where employers spreadsheet them against each other and say, well, you don't do it this way, well, the other one does, I'm going with the other one, and they lose market share, and it feeds itself.
Mark, coming back to you on the issue of affordability again, and building on John's comment, your constituency, many of them are covered already by Part B or Part D, and nevertheless, what I hear is that they are concerned about the issue of cost sharing and affordability, even within the context of Part D and Part B. Could you talk about that? What's the view of your group around cost sharing and affordability?
Sure. You know, there's an awful lot of talk about cost and price, and not a robust dialogue about value. And I think certainly looking at our patient population, these are life-threatening diseases. For 65 years ago, there were no treatments for, and now we've made huge strides. We have to work together to demonstrate the value of these therapies to patients in a real-world setting. And there's just very little data on the value of these therapies to society. There's clinical trial data, but those are obviously specific patient populations. What is the value not just on survival, but worker productivity, quality of life? These are the types of data that I think need to come into the discussion so that you can have a rational discourse about what's reasonable on the cost side. We have commissioned and are co-authoring a study that just got submitted for publication we'll be able to talk about it when it does get published, to look at real-world Medicare data, 12 years worth of Medicare data across 6 different heme malignancies, blood cancers, to look at cost and survival. And you can see, based on analyses of those data, that we're doing really well in some areas where it's quite cost-effective and not so well in others. I'll just say this about price, because I think everyone can agree what isn't a right price. One that doesn't reward the innovator, one that the patient can't afford, and one that's not sustainable for the payer community. So if we can all agree on what the wrong price is, I think, again, developing a data set that shows the value of these therapies to society, we should be able to have a more rational discourse about what the patient should bear.
Thank you. So let me bring another factor in the discussion, which was part of the objective of the panel, is to see how we are using technology and innovation overall to improve the delivery system. So why don't we start with John again, how is CMS using technology in order to improve the delivery system, in order to help the triple aim that you were describing at the beginning?
Well, I think we talked a lot about that during earlier questions, but part of our strategy is to help providers see what's happening once those patients leave their 4 walls. And when you think about what an ACO is, or when you think about what a health plan that's achieving 4-star, 5-star status, when you think about a primary care medical home, the kinds that CareFirst has developed, the commonality is that those providers and those organizations will win if their patients are well managed after he or she is discharged from the hospital, after he or she leaves the physician office. And so we are trying to help providers better understand what is happening to their patients. So we share with ACOs, with bundled payment participants, with primary care participants, best we can, the complete data picture of Part A claims and Part B claims and Part D claims. It's, I think Chet would agree, far from perfect, but it's getting better. And but that's really the kind of innovation, is being able to share that complete view relatively quickly to help providers understand what is happening beyond the 4 walls of the physician office to hospital. And payers, whether it's CMS or others, will continue to push that direction. And we are trying to consciously build better systems of care, but to allow providers to use data, care coordination teams, systems, whatever you want to call it, to better manage that patient experience, to avoid coming back into the hospital, to avoid multiple high-cost imaging tests. And I think that's the real breakthrough right now, that we can share this information.
Thank you. Chet, how is CareFirst using technology to engage with patients and with physicians?
Well, I can give you a couple of examples and then a caution, because I think it's high-tech and high-touch together. But let me give you a couple of examples. We're encouraging everything from biofeedback. You can have a little thing on your wrist, gives you constant feedback about how you're doing, from your blood pressure to your heart rate to everything. We think feedback loops like that are inexpensive and effective. They get people more aware of their risk. Another example would be enhanced monitoring in the home, keep people out of the hospital. Simple example would be digital monitoring for a congestive heart failure patient that might gain 4 pounds in 2 days. Weight gain due to water retention, an immediate alert. Simple to do, inexpensive to do, monitored by nurses, a trigger before you actually break down and go into the hospital. Another is integrated voice data image that we are working with physicians on, where nurses, the care coordinator, the physician, and the patient be connected through integrated voice data image. And then online information to the physician at the point of decision. The idea that you could actually look, in our case, at a member health record of the totality of a patient that had multiple chronic disease and see all the services that they got, when they got admitted, when they went out, what happened to them, whatever it was. If they were getting mental health services that from some other provider, that those are actually in the integrated record. Available 24/7 online within 3 clicks to any treating provider. That kind of thing was unthinkable even a decade ago or 5 years ago. It is now fully online. Having said all of that, and I believe it is essential to have those capabilities, I am so struck with something else, which is that the patients that we are taking care of through our primary care medical home program, typically the multi-chronic. Here's the typical case. You're obese with heart disease, diabetes, and you're on 15 medications, and you're depressed, and you're easily confused. And you're at home, but you break down. And nobody's there for you. And it turns out that in many of these cases, the nurse becomes the absolutely essential ingredient. It is not about the clinical sophistication of your care, or the technology that you use, or whether you were cost sensitized to purchasing healthcare more wisely. It turns out that you actually need help on the most basic of human needs. And that we find that what patients do over and over and over again is start to rely heavily on the nurse for the coordination of their care. The nurse is there simply for coordination, not for caregiving. And when you put high tech together with high touch like that, and you engage the member or the patient, and you engage the primary, you give an incentive to the primary to pay attention, and you give an incentive to the patient to pay attention, because the waiver of their cost sharing is dependent on their engagement. If not in their own interest from a health standpoint, you actually get behavior change. It is neither high tech nor high touch, it is both. And the coordinative aspects of this are absolutely, we have found, essential to getting better outcome. One other final statement about the cost of a drug. If it costs a little bit more to have the right drug or the cocktail that you should be on, but you could get a better outcome, and that would lead to an overall better result for you and lower overall medical spend over time, then we should do it. And it should be done in accordance with a plan. And we put a lot behind those basic thoughts. And we will see whether we're right over time.
Thank you.
And just to support what Chet has said, we have started to analyze very closely the first year of the ACO program that came into the Medicare shared savings program in 2012. And the organizations that earned shared savings didn't just do one thing, just didn't better manage ER visits or better manage hospital readmissions. They did everything. They better managed primary care visits, better managed post-acute care spending, better managed hospital stays, better managed Part B drug utilization. And that, to me, supports the notion that it's not just technology, not just data, not just payment incentive, but it has to be tremendous care redesign at the ground level. And we are placing our faith right now at those physician organizations that are creating this transformation, that are particularly focused not just on one aspect of cost or quality, but the complete spectrum. And those are the organizations that will win to our payment models long term.
Any contributions from the patient side, Carl or Mark? Okay, so thank you. I think we promised that we're going to have a robust Q&A session with the audience, so why don't we open up for the questions from the audience? I guess should you stand up and talk there, or? Okay. Could you introduce yourself and direct the question?
For Policy Research. A question, Mr. Burrell, you just raised the point of understanding the full, I think, real-world impact of a therapy or cocktail of therapies on a total outcome. When a product is going through a regulatory process, there's an emphasis on efficacy demonstrated in a clinical trial, additional data, obviously, on full, quote-unquote, real-world experience that a payer is going to be interested in to try and understand the full value of that therapy. How do you close the gap between those two different demands from the regulator, then from the payer, so that it doesn't deter innovative therapies? Also potentially helps the innovator understand what kinds of data they should bring to bear through their clinical development process that would be useful or helpful for payers.
Well, I think it goes back to something I said earlier, perhaps, which is we have tracked results two ways. One is by episode of care. The repair of your left meniscus, simple example, not just the surgeon's fee, but all that was involved, and looked at that across a large population. If efficacy were looked at as to that kind of result, not just a narrower way of looking at it, it takes a database as complete as the one that I'm describing and John described, where you can see the whole view by episode, and then there's another way we're looking at it by total population result, total population health, stratified by illness burden. You have to look at the aggregate picture. But I would say it's complicated in the way you asked your question for a particular drug. What we're finding is the thing that matters the most is which specialist the primary care physician chooses. The two most important and value-laden decisions we have found in the whole equation, if you want to talk about value, a primary care physician in the commercial world, in the under 65 population, accounts for about 6 cents on the dollar in terms of total medical spend for what they do directly. But they make two most incredibly important decisions: when to refer and to whom. And I would say to you that no patient is in the best position to make those judgments. So when you think about an episode, most of the episode costs usually are not the primary. Some primaries make those decisions better than others. If you're trying to prove a point about a particular piece of drug or a particular biomedical implant or something like that, you have to look at the whole effect over time, and that effect is highly variable based on who the specialists are that are carrying it out. In our case, it's 94 cents on the dollar that are driven by specialists. But primaries are the pathway to them. And in Medicare, it's 3 cents on the dollar that's primary. And so how complete are the databases? I would say this, we were part of the Blue Cross Association. There's complete records on 88 million Americans. Holistic, everything that ever happened to them. And there may be partnerships between pharma and carriers, at least as the Blues are concerned, where those data could be used to inform what really is efficacious or not. There's no easy answer to it. And, but that's my sort of general reaction to your question.
Thank you. More questions?
Hello, I'm Colin Hill from GNS Healthcare. A question for Chet. Do you keep your members long enough for investments in their well-being to pay off for you? And if so, for which types of members does that make sense and where does it not?
That's a really good question. Let me answer it two ways. Our overall retention rate of members is in the middle 90% range, historically. Enter the Affordable Care Act. Let's take a look at the 150,000 people that came in. If you ask the simple question, of all of the people who came in effective January 1, who wanted a January 1 enrollment, how many paid the bill? Well, 20% of them disappeared in the first month. We're now something in the order of 35% of them have already gone. Not sure where. Just know that they're not with us anymore. And your point is well taken. So much of efficacy, so much of result is dependent on consistency and stability and awareness on the part of the person and on the part of their caregiving team. If it turned out, and I didn't mention this earlier, but if it turned out that what happens is a constant churn because people can't pay the bill, or they can't pay the whole bill, or they didn't really understand what they had to do, you're going to have a serious problem with trying to manage anything. We run attributions of people to primary care physicians. In other words, who did you actually go to for primary care? And those patterns are relatively stable over time, except when they get disrupted by changes in coverage. And so do people wind up shopping price on premium and creating discontinuity on a large scale? Major worry. Remains to be seen how that works out. So your point's well taken. Were it not for that, the stability at least we've had is in the high 90s, or not in the high 90s, mid-90s, 94 to 95%.
Thank you, Chet. More questions?
Hi, I'm Andrea Weddle with the HIV Medicine Association. We're a trade association for HIV physicians and researchers. And as Carl said, the ACA is an incredible opportunity for people with HIV. I mean, in the past, fewer than 20% actually had access to private health insurance coverage. Unfortunately, at least based on the early experience, we're not seeing coverage translate to improved access. And we have examples from our providers of patients stopping their drugs because of coinsurance. Providers are really being hit hard by the increased prior auth, not just for one medication, but for multiple medications, which overall increase the cost of care. So seems counterproductive. But so Mr. Burrell, it's really, it's great to hear your approach, your company's approach, and just wondering what's the best approach to educate other payers, including PBMs, the pharmaceutical benefits managers, on taking this holistic, big picture approach to healthcare coverage and cost and quality and overall outcomes for the beneficiary?
I think I would give you a short answer to that question. If what we are doing works, there will be adopters. If what we are doing fails, nobody ever knew anything about it.
Yeah.
And I have been regaled with advice that what we are doing will fail. And that acting in the manner in which I described, which is basically in patient interest and towards effective outcome and overall efficaciousness, that if you did that well, it is my belief that you will get a better result over time. And many, many, many people will say, do not do that. And certainly that is true in the industry that I am in. Are they right? Or is this general direction that I've described right? And a huge stake is in the outcome. And what John says about accountable care organizations and about not doing it's not the doing of any one thing, it's the doing of a combination of things, done consistently over time, with a sort of a purpose and a perspective and a philosophy that's consistent, matters. And I hope that the crosswinds that are created in the political debate and in all of the experience that is emerging with ACA, that those crosswinds don't rip that purpose apart and distract. But if you sit where I sit, I just make one thought plain, I guess. We're a nonprofit. We don't exist we don't have any shareholders. We don't pay any shareholder. We have only one goal, which is get care as high quality and low cost as it is possible to get. And do it in a way that we're not the only interested party. We would like to have interested providers involved as well. In the last 6 years, we've made the grand total of 0.3% a year. So when somebody says to you, the way many people say to me, you're going to blow it away on cost, you're going to lose a lot of money, you understand what that means to somebody who runs a company that makes 0.3% on $33 billion in billings. It's not a comfortable place to be. Yet you have to believe in something and you have to act on something, and we chose this, or I guess I did, and I'm responsible for it, I guess. So we'll see. If it works, there'll be followers and adopters, and if it doesn't, it'll go to something else.
Thank you, Chet. Any additions, John or Carl? Okay, so let's have a question, and please, this time not for Chet, so we vary. Oh, my God.
I'm sorry.
Sorry. This is to both Don and Chet. We know that there's a lot of focus on paying for quality. I think something that no one would deny is important. But knowing how long it takes to get a real valid quality measure of some kind that's peer-reviewed and tested and legitimate for a lot of different, from a lot of different viewpoints, how do you balance the push that we're hearing from a payer standpoint that you want to be paying on quality and that's it? How do you balance that with the time it takes to really get truly measurable quality metrics that are meaningful to patients?
Let's have John respond that one, please, John, so we vary.
We need to move faster on developing measures that are trusted and reliable. But where we have pushed the framework is not simply relying on clinical measures. We are much more reliant on patient experience measures. And what Don Berwick used to say when he was at CMS, if you had one measure to use, you would not choose clinical measures, you would choose patient experience measures, because that is the most valuable, the most meaningful measure that we can think of, and we are putting much more weight on those patient experience measures. Second is we are defining in our framework quality of care as total cost of care, meaning that in our hospital value-based purchasing system, our physician value modifier that's coming online, that the total cost of care is being defined as a total quality measure. So the more that is spent, the more that is ordered, that is driving the overall quality value measure that's being assessed on hospitals and physician practices. So yes, we need to move faster, and we need to go through the NQF process for consensus and push it as hard as we can. But we are much more focused on a more narrow set of measures that are meaningful, that are comparable across care settings, more focused on patient experience than ever before, and also more focused on total cost of care as a key element to total quality of care.
I would say very much the same thing as John has said. We have put a great deal of emphasis. The single most important measure that we use for quality is patient experience, patient engagement and physician engagement in the coordination of care of patients. Overwhelmingly, we think is the most important element. We do measure industry standard measures, HEDIS type measures, and this idea of comparability that John mentions is very important. We have, and it's overall population health. In our program, we organize something over 400 primary care teams throughout this region. Average team of primaries is about 10. Average team has about 3,000 members. And we look at the overall patient experience for those 3,000 members, team by team by team. And what is fascinating is that if you arrayed those teams from top quartile performers to bottom quartile, the average difference between the top quartile, and this is on total cost, between top quartile and bottom quartile is 25%. And then people say, well, that must be because they're taking less sick patients. Well, actually, they're not. The top ones are taking sicker ones. And that must be because they have lower quality scores. Well, actually, they're not. They actually have better quality scores. And it goes back to the point we started with, which is you cannot control quality, you cannot control cost without improving quality for a population of patients through an informed team of providers that actually pays attention to them. And it takes time, to your point. We've been in it into our fourth year, but the patterns have started to emerge fairly clearly, but it took that long to do it. It's not forever, but it's not overnight.
Thank you. So let's see if we have a final question, and I would beg that you make it to Carl or to Mark. To Carl or to Mark. Any questions for Carl or Mark? David Brennan has one. Let's wait.
David Brennan, longtime pharma member. Carl and Mark, I just want to go back to the point that was made at the beginning that Joaquin introduced regarding this Medicare report. Most of the media focus on it has been on the money and who got the money, and for obvious reasons. But I wondered, how transparent is it to patients that you deal with about where the quality is? Like, how good are they at finding the quality delivery that that John and Chet have talked about when there are better providers or not such good providers? Is that, you know, is that something that is as transparent as the money?
Thank you.
I can start. No. There's no Angie's List for, you know, where you need to go to seek appropriate care based on your diagnosis. I think it's a first step. And the hope is that there will be more data like that. I think there's a role for nonprofits to be accreditors, endorsers, potentially, of places where there could be appropriate diagnosis and care received. But right now, there is very little information. We are neutral when we talk to patients about what their options are. We obviously encourage them to explore clinical trials when possible. It's really foundations like us that are sources of that information.
Carl? Okay. Thank you very much. I think we're going to give you 10 minutes, so you have time to go to the different sessions. Thank you to all the panelists. You've been a great audience. Thank you. Good to see you.